Regarding the hip examination, it might be a cue for a GP notes or examiner hand rub, concentrate to the patient, develop a report, patient name, age, sex, and occupation. Uh, in history, pain is important. Ask him to point at one finger at the region. C-Stein is important to elicit. Um, Check about the onset, duration, site, character, radiation, intensity, relieving and exacerbating factors as well as neurological factors. Um, Check about the night pain or startup pain. You can also ask about some of the important questions like climbing upstairs, removing clothes, taking the shower, putting on clothes again, putting on socks, walking downstairs again, getting into the car, in and out, painkillers. Regarding further, we can ask about what has been done up till now, walking aid, what to wear, physiotherapy, injections, regarding childhood problems and how they were managed, regarding the medical history. If any other joints are involved, should we also ask? Regarding the medical history, diabetes mellitus, heart attack, stroke, breathlessness, and chest pain. Medical history is important. Blood thinners, steroids, drugs for rheumatoid arthritis. Regarding the social history, if the patient is married, staying with partner, housing issues, smoking, drinking, alcohol, and occupations. Family history is important, and birth history is important. Expectations sometimes is very important to ask, and you can summarize the history to the patient as well. Regarding the examination, the first of all to assess is a walking aid or a footwear if the patient is moving comfortably or restricted. Hands can give me an insight in rheumatoid arthritis. Uh, I will ask the patient to stand up and start inspecting from the front, check for the attitude, pelvis symmetry, quads muscle, general skin condition, lower limb, any evidence of ischemia, are the shoulders symmetrical, anterior superior spine, any pelvic obliquity. Inspect standing from side, lumbar lordosis, scars, swelling, abductor wasting is important to check, knee straight or bend. Inspect standing from behind to talk about the attitude, iliac crust, scoliosis, gluteal hamstring tightness, sacroiliac joint palpation can be done as well. Regarding Tettelberg cell test, sound side sags. So I will ask the patient to communicate. I'm going to test and examine the muscle of your hip joint, and I will ask you to stand on one leg, standing in front of the patient, and ask him to hold your arm for balance, or I will ask him to put his hands on the shoulder. I will ask him to lift one foot up, start by lifting painful side first, and stand on the normal side. Wait for 30 seconds. A positive tilt down is sound side sags. Patient puts pressure on the normal side for balance. It can happen because of neuromuscular, superior nerve injury, osteoarthritis, and coxa vara. Negative is when the patient does not put pressure on the examiner arm for balance. It might be normal or hip arthrodesis. Treadle test is positive in three aspects. One is nerve injury, other is fulcrum if it's affected, or there is a discrepancy. Ask the patient to walk, check for the gait. Important gaits are Trendelenburg gait. Patients move the center of gravity on the to the affected side to reduce the movement arm. Affected shoulder sways to the opposite side due to weak abductors or neuromuscular condition or coxa vara. Short limb gait, patients shift the center of gravity towards shorter side. Shoulder on the affected side dips down, and circumduction is possible in the longer side. Waddling gain happens with bilateral TTH, foot and patella progression ankle. In the tendril gait, the short stance phase of the affected side. Flexor and adductors are stronger than extensor and abductors. So attitude of painful hip is flexion and adduction. Ask the patient to lie down, reconfirm the findings, uh, Start palpating anteriorly, check for any tenderness in the great trochanter region, do a Thomas test. Thomas test is for a fixed flexion deformity. Hugh Oman Thomas explained it, described it in normal hip flex to eliminate lumbar lordosis. It should be avoided in total hip replacement. Keep the hand behind the lumbar spine. Ask the patient to press the knee against the table or press it yourself. The angle subtended with the long axis of the thigh and the couch is the fixed flexion deformity. If excessive flexion of the normal hip can cause fixed flexion or deformity of the pelvis and can be false. Check for knee extension for fixed flexion deformity. That is a Stahili version. If knee has fixed flexion deformity, hang knee on edge of the table to assess the fixed flexion deformity. Now, after Thomas test, I will do the range of motion test, flexion, extension, abduction, adduction, interrotation and external rotation, inflection and extension. Both should be tested. Start with active and do passive. Length discrepancy, you have to check the apparent length and true length. If it is the apparent length which matters for the patient because of tilted pelvis or flexion deformity of the hip or the knee or adduction deformity. A true length is then when you square the pelvis, make sure the pelvis is square and leg is equal. Apparent length is measured from the xiphisternum to the medium malleus, and then after the difference in both of the length measurement could be due to pelvic tilt or flexion deformity. If there is adduction deformity, you need to measure it in adduction. If there is abduction deformity, you measure in abduction. Regarding testing the leg length, Galeazzi test is important. Flex the hip to 45 degree, knee 90 degree, may lie together. Check for projection of femur and the knee. The length is by the femur and the height is by the tibia. Create a digital Bryan triangle. For supratrochanteric shortening, do only if Galeazzi is positive, no need to do if otherwise. Thumb on the anterior superior leg spine to index finger at the tip of great trochanter. The peripheral distance with index finger do simultaneously on both hands to compare. Nalaton line is a hip flex to 9 degree. Patient on side. Anterior superior leg spine to the iliac tuberosity, a line is drawn, and a tip of the great trochanter should lie distal to the line normally. Now check for the test for impingement, flexion, adduction, and internal rotation is test for anterior impingement. Extension, abduction, and external rotation is a test for posterior impingement. Anterior impingement, flexion, adduction, and internal rotation. Posterior impingement, extension, abduction, and external rotation. Patrick Faber test to check the SI joint. Check for ischiofemoral impingement, hip extension, adduction, and external rotation. Now you can check for the muscle contractures. Ali test is for rectus femoris. Prone the patient, flex the knee, and the hip will get flexed if the rectus femoris is contracted. Oba test, lateral position of the iliotibial band. Hip to be tested is flexed, abducted, and 45 degree. Hip to be tested is flexed, abducted to 45 degrees, and then extended. In case of tight iliotibial band, the leg will remain abducted instead of adducting. Fleb's gracilis test is for gracilis. Hip to be tested is abducted. The knee is flexed off the table. If abduction is more on flexing the knee, this means gracilis is tight because gracilis is going downstairs, down below the knee, attached to the SLR, and check for hamstring tightness. Neurovascular examination is important then after, and a hip joint above and below. Examine the knee in the spine and opposite hip as well.